Should I get started or wait a couple of minutes?
I think you can go ahead and get started.
Okay. All right. So hello everyone. I'm Sneha Jadhav. I'm a child psychiatrist. I'm one of the consultants for BHIPP, and I practice at Kennedy Krieger, and I teach at Johns Hopkins. So that's my work day. My topic today is managing anxiety, helping families manage anxiety. And a lot of that obviously is done in the primary care setting. So specifically addressing anxiety in the primary care setting. So I'm going to share my screen and we can get started. Um, Okay. So this is me. This is the topic, our topic for today, and then a little more about BHIP, which I think most of you are very familiar with. A bit about our partners and the grant support, the funding for the program. No conflicts of interest for me today for this presentation, and some of the medication treatment we discuss is will be off-label use of the meds. The objectives for today would be talking about developmental aspects of anxiety and determining when we think it turns into or runs into the disorder spectrum, discussing expectations from treatment with the families, and while we talk about medication and therapy, also talking a little bit about how self-help resources and therapists in school can be helpful. So starting off, something that we all are aware of, that anxiety is a part of growing up. It is necessary. It is something that helps babies and kids and teenagers and adults learn how to handle stress and crisis. So starting at the infant age, there are very normal anxiety patterns throughout the early years of life. And also the second part of it, that babies and kids and teenagers naturally normally grow out of those fears. So babies who don't have the sense of things ending or starting, or that when someone goes away, whether they're going to come back or not, they learn those things through play, through their experience, through reassurance from their parents, and that anxiety does pass as they grow older. And that process continues throughout our developmental years. So navigating that developmental piece, then thinking about when that anxiety turns into a disorder. So anxiety becomes a problem when it causes a problem, and as long as the fears are present and they're being worked through, we don't put it in the realm of a disorder. We encourage parents to work with it. We encourage kids to continue their developmental process. But when it goes beyond that, the information that we need to determine that it has become a disorder is, what is the normal baseline for the child and how different is their day? So essentially the impact of these anxiety symptoms on their regular life. What is the spectrum of problems? Is there like one issue? It's very focused, very specific, or is it sort of a broad range of activities and functions that are being affected? How long has this dysfunction and this effect been going on? So if it's the past week when they return to school, we're not going to call it an anxiety disorder. If it's been going on for the last 6 months, then yes, it's time to think of additional support. And basically, what is the level of impact on their day? Whether they're is it a little bit difficult for them to go to daycare, or they're completely refusing to do it, where the parent lands up staying home to take care of the child and taking a day off from work. So the level of the problem and the point at which that anxiety causes a problem is when we start thinking about a disorder. Picking up these symptoms and this disorder early is important, because anxiety disorders are one of the most common disorders we run into even in adult life, and majority of them have their starting point in childhood and in adolescence. And so anxiety symptoms present in a wide number of ways, and this does not cover all of them, but just some, um, knowing that it's a spectrum of presentations. So some kids are really just quiet thinkers and they just ruminate, and they have this, then there is a new situation, they have this deer in the headlight type of reaction to it. Some are very emotional and have crying spells or anger or frustration, or they can be clingy, really clingy sometimes. Some kids experience regression, so they may not be outwardly expressing worries or emotional distress, but the milestones that they have achieved, they might be falling back on those. As that one child we see in that picture that had a bedwetting accident and had probably was completely toilet trained by then. They can have trouble focusing, trouble falling asleep. Their appetite might be affected by the worries. Some kids have very specific fears and phobias. Some have very somatic symptoms, like when you see that older child that experiences palpitations, headaches, or dizziness, and that feeling of something really bad is going to happen, or I can't breathe, or that I feel shaky. And keeping in mind that eating disorders and eating issues and sometimes substance use have anxiety is a big can be a big contributor to those problems. So assessing these presentations, we have a few, or we have several tools. Typically, the history that is provided and the duration of symptoms and sort of the impact on daily life, as we talked about, that's usually the most helpful, because those are the things that we are going to address, and that's the feedback we get during treatment. Is this better, or is it still a problem? To assist that clinical assessment, we have scales. And the two that we talk about and use very frequently is one is the GAD-7, which is a very brief, short screener that can be used quickly and can be used repeatedly to monitor treatment response. And then the SCARED scale is a more detailed scale and has a parent and a child version. It has about 40 questions on it. And I'm going to, with the apart from the scales, we have family history to sort of give us a picture of how severe or how long has this gone on for, or has it been for other family members, and that might help us judge when to step up the level of treatment or hold it back at that point. And then medical workup. So sometimes when we really cannot, there isn't a story of this buildup of anxiety. There isn't a very prominent family history. There aren't triggers, and there's sudden onset of anxiety symptoms. Sometimes that medical workup does come in. In my experience, one of the things that we end up doing occasionally is thyroid levels, TSH or T3, T4, or T4. One other question that has come up, not frequently at all, but sometimes, is when we have very abrupt onset and very severe anxiety symptoms, the question about post-viral increase in anxiety and streptococcal titers has come up sometimes. So that's the spectrum of assessment, and I'm sure there's more that maybe I haven't thought about. I did want to say a little bit more about the scales. So the GAD-7 is brief, and it is that if that's what we have time for, that's a good tool. It's a screening tool. It's a good tool to keep track of anxiety, especially maybe for older kids when they also are able to give some details of their anxiety symptoms. This serves the purpose of assessing their main symptoms. It does not differentiate. It does not tell us about panic symptoms. It does not tell us about social anxiety. It does not tell us about separation difficulties. So the scope of that scale is very limited. And so if the primary issue in anxiety is one of these things, then the GAD-7 sometimes loses its efficacy. There isn't that view of how the parents are seeing it versus what the child is experiencing. So the SCARED scale, at least in the beginning, when we're doing assessment, I feel like it is much more helpful to me because it's not possible to go through all aspects of anxiety at that one evaluation or even in two evaluations. So it helps pick a few questions at least out of the wide range of anxiety disorders, and it gives that insight into most of the times, or a lot of times, the child's scores are much, much higher than the parents. And so that allows the parents and for us to know that there is a difference in how the child experiences anxiety versus what's visible. So with that assessment, or after that assessment, we want to sort of document or indicate what the prominent cluster of symptoms is, whether the focus of treatment is a generalized anxiety, social anxiety, separation, is it a specific phobia, or is it panic disorder? So these are the DSM anxiety criteria, diagnoses. So we've done assessment, we've given it a diagnostic label, and then we come to management of anxiety. And so the three aspects of management and to be knowing and regulating the environment of the child, then considering very early, not then, but at the same time considering therapy, and then also giving a thought to whether medication is necessary at a given time in treatment. Go back just a little bit. So developmental anxiety, or when we're at that cusp of this is developmentally normal, but it's gone on for too long, or there is a clear trigger and we think it might get better, but we're not sure if we need more. So then our environmental measures come in very quickly, because this can be done without involving just with the family and the child and the primary care provider. There is no wait time. There is no insurance. So there are no roadblocks in the environmental measures. And so providing very concrete and basic facts of the situation to the child, giving them some control in the matter that is causing anxiety, creating sort of a predictable routine during the day, helping them focus on self-care in different ways, and helping them relax, getting them some physical activity and exercise. Those measures tend to help a large number of children, and they can sometimes be enough, few times can be enough on their own, but a lot of times they are a very important part of the whole treatment plan, even if they are on an SSRI or in CBT. And then being aware in terms of environment, also being aware of the parents' responses to situations, their modeling, their history with anxiety, and how they compensate or not, accommodate or not around the child's anxious behaviors. So those are the environmental things that can be put in place right away before we go further with treatment. Then we're thinking about therapy and or medication. I think discussing the expectation from treatment is a really important discussion. Starting with the fact that anxiety is normal, we're not looking to do away with it, because in early life, it is something that helps us mature and learn. As we grow older, it gives us that drive to do better, to be braver, be more efficient. So what the goal of the treatment plan is focused on managing the problematic parts of anxiety, but we're not trying to eliminate anxiety. And that working on anxiety is going to be hard work. And a lot of that work will be at home with the parents and the kids. And so it's not majority in the primary care doctor's office or in the therapist's office. Majority, that is just 30 minutes. Majority of it is at home. That parent participation and active participation will be the focus. So I hear parents say, we're doing therapy, but they want to work with me. They don't want to work with Johnny, because if he had the coping skills, we wouldn't have to do all of this, surrounding him. So explaining the parents' role to them can be very helpful in them sticking with therapy, and also sort of having that active part in improving the child's coping skills. And that therapy and the behavioral work and the parent work, all of that is about 70% of the treatment. And the meds are there to prevent or to minimize crisis, to sort of make sure that therapeutic measures are successful, but they don't take anxiety away. This discussion, I think, has helped me stay out of that loop of parents or children coming back and saying, when I enter the classroom, I still feel anxious. Can we go up on the medication? And that's just not how we discuss things, because we said that anxiety is always going to be there. So the fact that you feel anxious when you step into the classroom is expected, because that's how your brain has learned to respond. That's how it's been responding. We're going to work on the dysfunction is when you leave school. How do we help you stay, and how do we help you work through it? But the fact that you feel anxious is not the problem. And so I think this goes back to our environmental measures for addressing anxiety. And some of what we talked about is developmentally normal, making sure that the parents are not, or school or other adults around kids are not feeding into the avoidance behaviors or regression, keeping a routine, keeping self-care, the importance of self-care, social connections, and then being aware of anxiety in the family. And then a couple of things that can be done almost daily at home, having some kind of a daily check-in. So the thermometer, the emotion thermometer is one option. The other is using smiley faces, using a drawing, a color to describe the day, or a number, but something that the child and the parent can just talk about as part of the day, instead of how are you feeling today? Are you feeling anxious? And then kids don't really want to answer that, or don't know how to answer that question a lot of times. Some relaxation and breathing, which is again very basic sort of anxiety and mindfulness type of activities. And then having some time, especially for the younger kids, but equally important for the older kids, is those 5-10 minutes that they have the parents' attention, and they can decide what the two of them or the three of them do, the child and the parent or parents. And so that's some of what we talked about in terms of having control and being able to decide, having the parent available and being able to decide what activity we're going to do, as short as it is. That goes a long way in creating comfort in talking about how kids are feeling, but also knowing that the whole entire day and the week is not focused around managing anxiety. There's just this stress-free period that has no demands, that has no requirement for them to work through anything. And so we talked about environment. The second part B of anxiety management is therapy. And so the slide, a couple of slides back, is that CBT is clearly, that is plenty of evidence. CBT is very specifically helpful for anxiety symptoms. The response is anywhere from 55 to 80%. So we do want CBT for anxiety treatment. Asking for and following up on and making sure that that these are getting done, but specific elements of CBT, like asking for specific elements of CBT in therapy, might be helpful. So if it is a anxiety episode triggered by a life event or by a stressor, then supportive therapy is what they might need. Or if there's been a crisis, the first thing that the family or the child might need is supportive therapy. And so we're not looking at addressing negative thoughts and addressing behaviors and that triad yet, but at that moment, supportive therapy is most relevant. If it is a question of anxiety symptoms that have been around for a long time, we know there's rumination, we know there's fixation on things, or negative social sort of interactions due to anxiety, then very basic CBT with that circle of thoughts, feelings, and behaviors, that's what we want to ask for. If anxiety is leading to disruptive behaviors, like kids who have tantrums or will have a outburst at school so that they get to go home, and if it's a younger child, then it's the beginning of the work is through parent management training, where the parents in school know how to work around this behavior and prevent that avoidance, before we get to working through the CBT measures. So then that first referral would ask for parent management training. If we are seeing a lot of compulsive or avoidant behaviors, then we want exposure response prevention part of CBT. It is still CBT, but we want that specific measure, right? So that these very identifiable thoughts and behaviors start decreasing. If there is the next one is CBTI on that list for insomnia, which is a specific therapy for sleep. It includes sleep hygiene, but much more than that. It is, I do work with therapists who do it within a time frame. So again, it's not a forever kind of therapy. I mean, you can always return back if you need a booster, just like with any therapy. But if insomnia or worries and anxiety around bedtime is the most prominent feature, then we want to ask for CBTI specifically. And obviously, if there's a clear trauma trigger, then we want therapy that's trauma focused. So while we broadly talk about CBT being the best therapy and the most effective therapy, asking for specific elements of it, depending upon what the child needs, usually has more satisfaction, shorter time frames in achieving goals, and the child and the question back to the treating physician is about increasing medication or addressing medication tend to be lower because we are specifically addressing things in therapy. Then coming to the medication discussion, same thing as we talked about with treatment in general, that the role of medication is to support the success of therapeutic behaviors and improve the tolerance of anxiety. We do not, and we cannot, and we don't want to eliminate anxiety. And talking about, especially because a lot of the treatment is with through SSRIs, talking about the time to therapeutic effect and that we're not going to see improvement in the first week, days, or first couple of weeks. And then the discussion about side effects, which we're quite aware of, and we can talk a bit more about the side effects. Next slide. Okay. So the specific medications that we use, and these are a very familiar slide for everyone, that are FDA approved are sertraline, fluoxetine, citalopram, and duloxetine. And then the FDA age approvals are in brackets under them. And this, we do want to start at the smallest available dose. So for sertraline, it's 12.5. For a child that has never been on medication, 12.5 to 25 for sertraline, 5 to 10 for fluoxetine, 5 to 10 for Lexapro, and 30 milligrams is the lowest for duloxetine. And then the maximum doses are in the next column. So the basic steps that we take with SSRIs, like I was just saying, we start at the lowest dose that we think will be tolerated, not effective. The first dose, a lot of times, is not the effective dose, and that's okay. We go slow with the titration. We want to see some results by between that 4 to 8 week period. If that does not happen, then we want to go back and reassess if the medication, if we match the medication well with the cluster of symptoms, and there may be new information that has come up in that month or 2 months, and so whether we've incorporated that and does that medication still make sense. If we are seeing some results, then giving it that adequate dose and timing trial. So we want to optimize the dose, and we want to give each dosage change about 4 weeks to show its full efficacy. A couple of other facts about SSRIs: the effect size is 0.7. And for comparison, treatment with stimulants, the effect size is 1. So that's the level of change in symptoms that we expect if the medication is working amazingly well, flawless. And again, this brings back the point that we are not going to, and the goal is not to eliminate anxiety. The other fact I think that's interesting is the number needed to treat anxiety. Not talking about OCD specifically, but is 3. So if we treat 3 kids with anxiety, one of them is going to do really, really well. And the other 2 might have a slightly subdued response. But that is a really good NNT compared to for OCD, it is 6, and for major depression is 10. So a child with major depression or children with major depression, you would have to treat 10 of them to have one uh, really good response out of that. So it's easier, almost more sort of easier to treat anxiety or see improvement in anxiety. And then the discussion about the time to therapeutic effect with SSRIs, having to wait those weeks until we see effects, and talking about and sort of having that maximum dose in mind, that we're not giving up on a medication too soon if it has shown some improvement in the beginning. So the basics about SSRIs, the next part becomes the side effects. Most kids tolerate SSRIs relatively easily. So we typically don't see any side effects, especially if you're starting at that low dose and then checking in before we step it up. If we see side effects, the common ones are stomachache, nausea, diarrhea, GI side effects, headaches. Sexual side effects, I put them up there. The discussion about sexual side effects is not, I think, as frequent with teenagers as we do it with adults. The reported sexual side effects are pretty low in the teenage studies for anxiety. But partially, I think that is because I don't think this is a very common thing that we discuss when starting medication. And so whether they feel comfortable reporting that or recognizing that this might be medication related, I'm not really certain of. In the adult world and in the adult literature, about at as many as 30% of folks who are on an SSRI at some point have some complaints about sexual side effects. So we just have to probably be a little more aware and kind of start bringing that up at least at some point in treatment. The less common than the first set are symptoms of activation, which is restlessness, irritability, sometimes an increase in anxiety or difficulty sleeping. This side effect tends to be more common in the younger kids, especially in the 8 and under age group. So the younger the child, it's a little more common. We can usually get past it with small doses and with slower changes and just kind of just toning down that whole process overall. But it is common enough that this should be discussed, just like we discussed the black box warning. And then hypomania is a pretty rare, like a switch to manic or hypomanic mood is pretty rare. A lot of times when there is that irritability and change in baseline, it is more under that activation spectrum than manic symptoms. But it is a theoretical possibility. That we need to be aware of. The black box warning, I'm sure we've all discussed with parents many times, and we can talk more about that if we want to. Very rare, but just such a serious warning and a possibility that we definitely want to mention it at the very first discussion, but also after the child has been on the medication for several weeks, because that initial discussion sometimes slips. And then as we titrate the dose, we want parents to monitor for this also at the same time. And serotonin syndrome, again, a very rare side effect that we run into, and discontinuation syndrome. So if the child has been on medication for several weeks and then they suddenly go off of the medication, having sort of these flu-like symptoms, muscle aches, feeling dehydrated, that cluster of symptoms can come up with suddenly stopping medication. Least commonly with fluoxetine because of its half-life, more common with medicines like Effexor or Paxil, which we typically do not use in children. And then a little more specific information about the black box warning, which came out which was put out in 2004. The basis of that warning was that a meta-analysis of several studies showed that the rate of suicidal ideation, the risk of suicidal ideation, in the non-treated group or the placebo group was 2%, and the rate in the kids who were on SSRIs was 4%. This was suicidal ideation only. There were no attempts. There were no completed attempts. But that risk was clearly different between the two groups. Once this warning came out, the prescribing practice around SSRIs changed, and the prescriptions dipped. And that, the following few years, there was a very clear, noticeable increase in suicide rates in teenagers. And that's the largest sort of increase that we've seen across 1 year or across 3 years since the CDC has been monitoring these numbers. One other aspect to that is, since we're talking about anxiety specifically today, that one of the established and sort of organized nice study for anxiety was the CAMS, the Child and Adolescent Anxiety Multimodal Treatment Study by Dr. Walkup in 2008, which looked at treatment of anxiety with SSRIs and CBT. And in that study, the adverse events like suicidal ideation were the same in the SSRI group as in the placebo group. So if on those occasions that we are purely treating anxiety and there is not an element of major depression or previous self-harm thoughts or actions, I do like to bring this to the parents' notice or to kind of say it out loud, is when we're purely treating anxiety and we're kind of starting off, we are at a low risk for any self-harm thoughts or behaviors, that we don't expect to see that side effect as much. And a little more description of the serotonin syndrome. It's a really rare issue, especially if you're only treating with SSRIs and there isn't a second serotonin medicine on board. This question comes up often if the child is on triptans for migraines or 5-HTP supplements for migraines. That's when we can start watching for this issue a little more closely. And then discontinuation syndrome, like we just talked about, if kids suddenly go off medication. Some sort of self-help resources. So we've gone through environmental issues, or management strategies. We've gone through therapy, medication, and then some things that might be helpful for us to look up, to go back and see what the facts are, or to present to families so that they can see that there are guidelines in treatment of anxiety that can be a very, like if they go to the ACAP website and say, okay, this is what we are doing in treatment, and these are the guidelines, that can sort of take away a lot of questions and worries for parents. And then I put the two studies on there, which had a large number of kids and had good, useful insights into anxiety treatment. These are a few books that I have come across, heard from parents. The Coping Cat is what we talk about and use and look into most often. There's a younger kids version and there's an adolescent version. And then some of these are more specific to teenagers, like the Turnaround, the Tiger book, The Fighting Invisible Tigers. And then The Gifts of Imperfection is a good sort of insightful book for which teens can definitely read, older teens, but it is directed towards perfectionism and obsessive traits. And then the rest of these are more directed towards younger kids. So what do you do when you worry too much, sitting like a frog? So just a couple of books for families who are interested in that sort of thing. And just one quick note about school, getting school involved, because it's part of every child's life. And if we are treating an anxiety disorder, it's rare that it doesn't show up in some way or affect the school day in some way. And there are obviously very specific school and anxiety correlations, like I've listed. So getting school, making them aware as early as the family is comfortable with it, and getting them on board is helpful. And so as the providers who are helping families get in touch with different things, assessing, getting in touch with what they need, and then seeing that they make it through all of those different modes of treatment. Our role starts with helping them decide when we can just monitor anxiety or address it with measures at home or in the community versus when we need therapy and when we need medication. Making parents aware of that environmental role and how to modify it. And then also sort of helping them see what the most effective measure is at that stage, not the measure that we want or that would be the easiest. That's where the guidelines and that initial treatment expectation discussion comes in. Setting expectations from treatment is also our role and our responsibility. And then, yes, we refer to therapy very often. We know that school is somewhere in the picture. Having some system of getting an update from them, even if it's twice a year or once a year, that tends to be helpful. With therapy, the kids that I do talk to kids about having a notebook, a little like a rectangular little square notebook, so that whatever they've done, because a lot of times if they've had a therapy appointment the previous day and I ask them the next day, they won't remember what was done. And as much as there's that intention, we don't always get to check in with the therapists every so many weeks or months. So that little notebook with that one line about their appointment is great because they can bring it to my appointment, just like they take it to the therapy appointment. And then when we have helped the child recognize, manage, and the family recognize, manage, and get comfortable with their anxiety, we also have to think about when is it time to wean them off medication, because anxiety medication is not built or thought of to be sort of a lifelong medication decision. And so also initiating that, because once they're doing well, parents and sometimes us, we're hesitant to sort of rock that boat. But there are SSRIs do most of their work within about 6 to 12 months once the child is asymptomatic. We know that that's usually how long the brain needs, and along with the medication, to be comfortable in dealing with stress on its own. So if we've had that sort of nice calm period over 6 to 12 months, we don't have any big new transitions or stressors coming up, then at least starting that discussion about weaning medication is also kind of falls in our treatment role. So there's the summary, which I think we already, that's what we talked about. And just a bit more about contact information for BHIPP. Get in touch with us. And that was it.
Thank you so much, Dr. Jadhav. We did have one question in the chat, and we'll use this last a bit of time for some Q&A. So if anyone else has any additional questions, please feel free to put those in the chat now. Dr. Jadhav, we had a question from Erin Murley, and she was wondering about, sorry, just lost the spot there. What do you think about manualized CBT in primary care, such as the coping cat? I know you briefly touched on this.
What do I think about it? Coping Cat was built so that was made or is made around the understanding that an adult who is interested and is able to spend one-on-one time with the child, that workbook is simplified and manualized enough to at least initiate that conversation about anxiety and to start recognizing where the work is and what the work is, and helping the kids develop some insight, give them some expression for it. So it's great. I mean, whether parents buy it off of Amazon and have it at home, or whether it is in the primary care office for even those 10 minutes that can be specifically, I mean, if there's time for that, I think that's the question. I think that would be great. So there isn't a silo of where anxiety can be or should be treated. So when we have those 10 minutes, utilizing that and with the coping cat is a wonderful idea. Very effective.
Thank you. We had another question, if you have any assistance or recommendations for kids who are school refusing.
So school refusal is essentially an avoidance behavior. It's because it's school and because there are very specific rules about attendance, it is a separate issue. Avoidance is a part of all anxiety. So if I'm afraid of water, I won't go near water. It's like that. And so the basic idea of treating is that we don't promote that avoidance, and we find ways to help the child step into it. Sometimes it starts with waking up in the morning and just not being able to think about going to school. Sometimes it is, yes, we get there and then we have to someone has to walk them. The counselor has to come out and walk them to their class, or they won't go, or they get to school and they get really, really anxious about what's going on at home. So the one big part of it is having school involved early on in treatment, so that the child is not penalized for it at one end. The other part is that there isn't a reason for the child to not actually attend school. So it may be that we have to start with 3 days of just driving to school, like getting ready, getting dressed, getting in the car, driving to school. And that fourth day that they go and sit in the nurse's office or the counselor's office and do their work there for the next 2 days. And by the end of the week, they are starting to step into the first class of the day or the second class of the day. Sometimes it's the day starts with math and that's their whole, or reading, and that's their whole fear, because that's how the most difficult part of the day is the starting. So sometimes what I've done is written to the school or talked to them about letting them start the day in the second class, or let them do the first class separately from the rest of the class. On the other hand, some kids have a hard time sort of walking into a school full of kids. And so getting them permission to go in early or go in like 10 minutes later once everyone's settled, because that hallway full of commotion doesn't work for them. So we have a bit more of a work in figuring out what the triggers are, what the hardest things are at school, and just helping the child get ready. First, get ready for school. Second, get into the transport bus or car. And third, enter the school building. That's the goal. So we're not starting off saying they have to go all day, they have to complete their assignments, and they have to do everything, the extra activities that are asked for. We might have to get them some accommodations with the demands, as long as we keep that daily attendance. So meet the child where they are. Just, we do not want avoidance. We don't want the child sitting at home with a stomach ache, because then if they do that on Monday, Tuesday is going to be just harder. And if they haven't gone for a week, the next week is going to be horribly hard. The last thing I will add there is we do not do a home and hospital for school avoidance and for school anxiety, because that does not help. It hurts the child's return to school.
Okay, we have another question on how do you speak with parents who are accommodating the child's anxieties, so avoiding stressors, and encourage them against this?
So starting off that, I mean, we know the developmental aspects of anxiety, but when a parent sees their child struggling with something, the first instinct is, how do I protect my child and not have him go through this difficult phase? So it's a lot of talking, it's repetitive talking, and it's about the fact that anxiety is developmentally normal, reminding them that when they were very little, they were afraid of the babysitter or their first day at daycare, and then by the end of the second or third week, they were having fun. I ask parents sometimes about examples where the child has worked through some of the things that they were scared of, and that even if they know it, that gives them that background of I can work through things. So, and just saying those words, oh, we really need anxiety in our life and we want it, and it drives us again and again, can be helpful. The third, I think, is also telling them that, or sort of explaining, reiterating that we can't convince people that there's nothing to be anxious about. They have to prove it to themselves. That's the only way it works. So if we take the first step, my child is very scared of going to a birthday party. I can't take him. It's such a big outburst and a sort of a family conflict. If the child, the only way that's it's not going to be, we do so much therapy and then we start a medication that, Lisa feels fine going to a birthday party. It's going to be, she takes small steps. She proves to her brain that she can do it. And then she takes the next step and she proves to her brain. So whether it's parents, whether it's the kids, they're the only ones who can collect evidence for that fear. And that discussion just kind of has to repeat itself. And we do get through that accommodation, eliminating or minimizing the accommodation. One of the things that's done in therapy, and sometimes we have to reiterate it, even if I'm not doing therapy, is writing down very specific things. Like when they say my stomach hurts, you do not take them out of the car if you're getting ready to go drop them. If you can't move forward at that moment, that's fine, but you stay there. Obviously, they need some coping skills that they worked about what to do when that anxiety increases. But so sometimes they need very specific written down things, is don't leave the car when her stomach hurts, or telling the school and the parent is when they start going to the nurse's office, offer them sort of hot compresses, cold ice, snack. Do not call the parent, because as soon as there's that option of the parent coming in and picking them up, it just becomes a reward for the anxiety. So right from that generalized discussion to very specific, like pick one behavior. There may be more than one avoidance behaviors. So we pick one avoidance behavior, give the parents 2 or 3 specific things to do and try it out. And then also prepare them that anxiety will get worse before it gets better. That's really what I have done.
Thank you. It looks like Dr. Regina George asked a question. When do they need medication? Should she start with CBT first? And if it doesn't help, then start medication?
So CBT has great evidence. So yes, CBT is a yes. And if we start with CBT and then add medication, that is 99% of the times, that's a great answer. And that's perfectly fine. It depends upon what we have to achieve practically and how much time we have. So if it is a child who's just been at home for the last 4 weeks already, has missed school, and is about to get a letter and has tons of assignments that are piling up, and it's a high school, and we're making the referral for therapy now, but as we know, therapy might start in 6 weeks or 8 weeks. That dysfunction, because the longer that effect stays, we are providing evidence to the brain that this is really a big issue. It is something to be afraid of. Staying at home is nicer, and that is the way out. So the goal is usually to break the anxiety cycle. If we can break it relatively, in a reasonable amount of time, without the child missing out on the developmental stage or phase, we wait with the therapy. We start therapy and we wait. If we are really at the point, we're seeing them later in the course of the symptoms, or there's so many things involved that the child might miss out on something on the end of the year, on a sports event, then I think starting both of those measures together makes sense. One reason for that, and both the studies that I listed have those two arms of CBT, medication and CBT both. And obviously the kids who had both did the best. But I think we are addressing the question of how long do we wait, or do we wait? One other point I wanted to make is most therapy for anxiety asks the child to step into outside their comfort zone and to accept some increase in anxiety. And so if the anxiety level is up here, expecting the child to participate in therapy, which says, okay, now I want you to be comfortable. I'm going to give you a little more anxiety. I want you to be comfortable with it. It's too much of an ask. So sometimes the success of therapy might be related to bringing down that severe anxiety level with the help of medication. So that's the other time that just in talking to the child and talking to the family, if I feel like they're not at a place where they can step into therapy actively and be invested in it, then I have a lower threshold for starting the medication.
And Dr. Jadhav, we have another question. What is your advice for families who are reluctant to try medication or therapy treatment for anxiety for their children?
For families who are reluctant for therapy and medication, both. Practically, the self-help resources that we talked about, even sort of helping the parent and the child formulate anxiety as an actual health issue can sometimes happen when they are sitting with a book rather than in those, hour or 30 minutes that we have with them in the clinic. So if we have the time and the room to do it, as in there's no crisis and there's mild symptoms, then yes, helping them come to the point through maybe the self-help resources. One other thing might be talking to them about support groups. Like NAMI has support groups. ACAP has some family resources listed where families can communicate with each other, like if it's a support group of kids. That might be something that hearing or coming across the experience of other parents might have a little more realistic sort of importance to them than talking about treatment in the office. I'm trying to think what else. I think sometimes, so talking about the child and the family as a whole, but the child's goals. So if the child's goal is to have a job in a saloon doing hair, someone's hair, want to be a cosmetologist or a hairdresser. And right now they're completely not going to school and completely avoiding it and or have social anxiety. Working back from that goal and sort of saying, okay, if we want to achieve that when we're 25, we want to be a hairdresser or a beautician, or what would you need to do at 24 or 20 or 20? So connecting it with their goals and sort of how it is keeping them from achieving that, that sometimes is helpful, especially with the older kids. And for the younger ones, the parents' goal for the child, like, I would like for her to be able to have friends, and I would like for her to, working backwards from those goals sometimes is helpful, very specific ones. I think that's all I have.
Alrighty, if there are no additional questions at this time.
Can I just say one more thing?
Yeah, go ahead.
Sometimes, I mean, school is such an important resource for us. The school counselors, like if the parents are okay with it, if for this last question of parents who are not willing for treatment or for therapy or medication, asking if we can just reach out to the school counselor and get them involved and sort of start working with them, because that seems more of a non-treatment setting. And sometimes they can help parents recognize how the symptoms are affecting the child's day. And school counselors have seen kids, and they have a lot of experience with kids who have gone through treatment and or not, and the impact of that. So that might be another resource to tap in.
All right. Well, thank you so much, Dr. Jadhav, and thank you again for everyone who has joined us today. As a reminder, all of the slides, the resources mentioned, and a full recording of this webinar will be posted on our website by Monday afternoon. So thank you again, and have a wonderful day.
Thank you, everyone.